Hi, this is Tom Lüscher and Inside Cardiology. And today we talk about the future of cardiology and the future of the cardiologist. And now let's go back a little bit in history to think about where we came from and where we will go to. Now we started with observation, as you can see on this nice painting from many centuries ago, where doctors were basically describing a disease but couldn't provide more than tender loving care. And then at the beginning of the 19th century, René Laennec invented auscultation, and that is his first stethoscope, which basically is a tube, a wooden tube, but today it is of course much more sophisticated, but it remains the symbol of the physician, because for the first time physical examination became real. They could actually hear the hidden organ that the heart is. And then of course at the turn of the century came another fantastic scientist, clinician, Willem Einthoven, who in Holland developed the ECG, another fundamental tool that makes up the cardiologist. In fact, we spend hours, days and weeks to learn how to interpret the long and winding lines of the ECG. And today, the doctor has a stethoscope and he has an ECG. But it, of course, now went much further. We have an echo, as shown on the lower left. We have an MRI and we have a CT providing fantastic pictures, even moving pictures of the heart, allowing us to see the pump function, the function of valves and alike. And of course, now we are in the age of the digital transformation of cardiology, and DSC already took this up, and I made in the ESC artificial intelligence a major strategy. And you can see the first product we provide to our members is the ESC chat that allows to integrate, thanks to large language models, all guidelines we have, so you don't have to write and to read 120 pages of each of them and take a sabbatical to figure out what cardiology is today. No, you can ask a question and you get an answer right away. So this is a start of an avatar, a co-pilot for your clinical practice. Now the question is, how does this evolve over time? And of course, you can see that in the 18th century, when James Watt invented the steam engine, workforce, physical work, physical force was no longer as important. And then of course came Faraday, electromagnetism, and of course we had electrical engines, we had light and so forth. This changed massively our culture and our society. So intellectual work, as you can see here, became much more important. And the question is, to what degree is intellectual work as important in the future as it is today? And how will this affect the GP, the imager, the interventionalist of our field? And when I ask my favorite philosopher, Elon Musk, he said studying medicine and going to medical school is becoming pointless due to the rapid advancement of artificial intelligence and robotics. And the question is he right? Is he right? And so when we look at what AI can do in the journey that the patient takes when he sees a doctor, first of all, he's waiting for the doctor. Now, large language models are now trained for diagnostic dialogue. It asks you, how are you today? Any chest pain, any shortness of breath? I do this always when I run a clinic in London. And he says, the patient says, oh yes, when I have some chest pain when I walk up the stairs and so on. So the algorithm eventually provides for the physician, while the patient is waiting, some probability of diagnosis. And then the patient comes into the surgery and encounters the doctor. The doctor looks immediately at his face, at his body shape, body position, his gait speed, and you can easily make a first impression. But the algorithm actually, from the skin, from the wrinkles in your hair and so forth, gets further and provides some prognostic information and the probability whether the patient has coronary disease or something else of the heart. And then of course you talk to the patient, and the voice is a new biomarker. In fact, the voice will tell you whether you have an infection, whether you're congested, and it can even predict mortality and hospitalizations. Then you go to the ECG, and the algorithm on the ECG tells you how old you are, whether you're a male or a female. There is still clear binary information here. Then it will tell you whether your pump function is normal or reduced, whether you had atrial fibrillation in the past, whether you had amyloid or aortic stenosis. So you get more and more information in your computer, on your screen, when you see the patient. Then you go to the echo, and the echo now is analyzed automatically. It provides LVEF, it provides EE prime, it provides the speed, the velocity across the aortic and the mitral valve and the like. And then it may go to the coronary CT. And the coronary CT not only provides you the structural information, now AI algorithms can provide FFR, they can provide the fat attenuation index, and you get more diagnostic and prognostic information. And so basically, with medicine will evolve like shown on this slide, where we integrate with algorithms clinical information, biomarkers, imaging, then of course portable device information, genetics, and we can provide a digital twin. And indeed DSC now wants to provide a digital twin as a co-pilot for the patient to provide better implementation of guidelines. And the digital twin, of course, is the basis of personalized medicine enhanced by AI. So what will be the phenotype, the skill set of the cardiologist of tomorrow? Talking to the patient will be more and more important because you have more time. Expressing empathy and building trust is the fundament of medical skills. Clinical expertise and examination is very important, particularly when data are contradictory or unclear. For instance, if you read about the implementation of or implantation rather of occluders of the left atrial appendix, if you read meta-analysis positive, if you read a recent trial in New England, it is increasing mortality. So that needs a physician to look at what is actually the information that is relevant for this patient. Clinical judgment, more and more important, and physiological reasoning. Then of course literacy of artificial intelligence, understanding the strengths and limitations, and also the potential of hallucinations of algorithms. So we need to train ourselves to be critical here. And of course we need to consider ethical and privacy issues. Manual skills, however, will still be the major skill of interventional cardiologists and electrophysiology, as well as surgeons, for a long time, because robots, unlike what Elon Musk predicted, will take much more time to beat the fine-tuning of a skilled manual hand. And then what is less important is of course ECG reading, and as algorithms see what we don't see. Image analysis also here, it sees what the algorithm sees what we don't see. So for radiology and imagers at large, this is bad news. We will need much fewer of those cardiologists and radiologists, and then administrative skills may also be less important, because algorithms will sort out the referrals and so forth and improve the workload of our physicians. The search for information will also be easier You don't need to know exactly how to do it. It will be provided to you through the algorithm. So, do we need a new curriculum for doctors and cardiologists in particular? So the essential skills or the career in cardiology that you find on the ESC page needs revision, because in the framework for training and learning in the time of artificial intelligence will be different, and we will work on this, and we need also your input to get us ready for the digital transformation of cardiology that is happening as I speak. Thank you very much for your attention.